My name's Mike Edwards and I'm the Director of Service Delivery for the New South Wales Rural Doctors Network, RDN. I have the pleasure of introducing Dr Pat Oakley, who is currently the Senior Staff Specialist in Aboriginal Chronic Care and Senior Staff Specialist in General Medicine at Hunter and New England Local Health District. Dr Oakley was schooled in rural New South Wales and completed his HSC at Kempsey High in 1985. Dr Oakley graduated Bachelor of Medicine Newcastle University in 1991 and passed RACP written and clinical examination in 1996. Advanced training was completed in 2000, clinical pharmacology and toxicology, including 12 months nephrology, non-core, and then fellowship in general medicine at Calvary Mater Hospital, Newcastle. Patrick worked for 12 months on the Sunshine Coast as a general physician at Noosa Hospital, with a fractional appointment at Nambour as a nephrologist and clinical pharmacologist. Since 2002, he has been based at John Hunter Hospital, Newcastle, primarily as a general physician. From 2002 to 2007, he was Director of Physician Training. In 2009, Patrick was appointed to the National Examiners Panel, Royal Australasian College of Physicians, leaving this role in 2018. In 2007, Patrick began providing a specialist medical clinic at Armigen Aboriginal Medical Service in Inverell. This has continued. In addition, he now attends more rural clinics at Glen Innes, Inverell, Tamworth, Muswellbrook, Taree, Cessnock and Awabakal at Newcastle. In 2012, Patrick was appointed Senior Staff Specialist in Aboriginal Chronic Care Primary and Community Networks, Hunter New England Health Service. He continues in general medicine at John Hunter Hospital as well. From 2015 to 17, Patrick was clinical lead of the Chronic Disease Network as well as Hunter New England Health Service. He will now be speaking on the model of care for those rural towns. Thank you, Pat.
G'day, I'm Dr Pat Oakley. I'm a specialist at John Hunter Hospital working in Hunter and New England Health. Thank you very much for inviting me and my team to present at the RDN Congress this year. I'm also in the company of Alwyn, Duke's Aboriginal Health Worker, based up around Moree. Is that right, Alwyn?
Based at Moree and work in the Mei cluster. Yes.
Fantastic. So we're going to talk a bit about the model of care, of the way we're trying to provide specialist medical clinics for people up in rural H&E. So go to the next slide, which basically shows. Oh, before I do that, so I'd like to acknowledge, with respect, the traditional owners of the land we're standing on today, which where I'm standing is the Awabakal Nation. And Alwyn, I'm not sure where you're standing, mate.
Kamilaroi country.
Excellent. I'd like to pay my respects to all elders past, present and future. So getting to Hunter and New England Health, it's a very big LHD. It's the largest LHD by area in New South Wales, so 131 square K. The population is only just a bit under 1 million people, and if you can imagine, the people are spread far and wide outside the cities and tertiary hospitals. We've also got the largest number of Aboriginal people in our LHD compared to the others, and again, they're widely spread from, as you can see, Mungandai up at the Queensland border, all the way down to Merriweather in Newcastle, which is probably the most upmarket suburb in Newcastle. So you can imagine we've got a great diversity of people with healthcare needs and a massive geographical area to serve. Okay, I'll talk about my job because that's what I know the most about. So I've had my current job since 2009. When I was appointed to being not only 0.5 staff specialist at John Hunter, which is a big hospital in Newcastle, but at that point I took on the 0.5 role with the Aboriginal Health Unit to provide specialist care for Aboriginal people with chronic diseases. And that was a new job that was created specifically with this focus in mind. I'm also the supervisor of advanced training in general medicine at the John, and that's really handy because I think we need to take the opportunity to educate training physicians to work outside of the tertiary centres. I've also got access to the junior trainees through previous work as a network director of physician training and my work as an examiner. So I think for me that access to future physicians is fairly important to me. The other part of my job is obviously to work with people from the Aboriginal Health Unit, the nursing staff from the ICCAP, of whom there's 4 CNCs covering only the 131 square K, as well as all the Aboriginal health workers and a number of Aboriginal medical services. The way we deliver these clinics is 3 main ways. The first one I became involved with was going to Aboriginal medical services, beginning with Armidge up at Inverell, and since then quite a few more. The other face-to-face clinics we do are actually organised at Hunter New England facilities, and I'm quite proud of these because I think we had to overcome a lot of hurdles in terms of community engagement with those. All the clinics that I do, I bring an advanced trainee in general medicine with me so we can effectively double the capacity and, of course, attend to their training. We've got 4 OTs every year, and they're attached to us for 2 years, which I think serves some continuity of contact there. We also take a little junior doctor with us, an RMO, who I think is benefiting each time from the experience. The other modality of care we provide is telehealth, and the demand is sufficient that we now do once a week telehealth clinic. On top of that, if there's the need and I can do it, we do a bit more ad hoc stuff, particularly if Alwyn rings up and needs a bit of help with somebody, we can usually swing something within a week. So looking at these different modes, the Aboriginal medical service-based clinics, they've been doing them the longest, and I now go to 6 locations, so Armidge, Tamsin, Tamworth, Coaldale, Birrapart-Taree, Wabbical, and Tolbooba. I'm happy to say I've handed over to one of my trainees who's now a consultant. So we go to each one every 2 months and provide that service, and obviously have contact in between times. The Hunter and New England health-based clinics are also every 2 months, and I go to Cessnock, Muswellbrook, Glen Innes, and we've set up a clinic at Moree, which is a telehealth clinic on a regular basis. And again, another of my trainees, who's now on maternity leave, has been able to take that clinic over, but I've got it back right now. Pivotal to the H&E-based clinics is the role of the ICCAP nurses and the Aboriginal Health Unit, and particularly the Aboriginal healthcare workers like Alwyn. All right, so to compare the two side to side, at the AMSs, the handy thing is the community engagement's done, and I think people are happy to attend and feel safe going to the AMSs when those same people would not be quite so happy walking into a hospital. The AMSs do all the coordination of the clinics, and that's generally a good thing depending on how experienced they are with running a clinic. The other benefits is that I can access their database, I can leave my notes in their file and record my findings, and I can have a chat to the GP on site to communicate any further important information. The Aboriginal Medical Service staff provide the transport for the patients as well. But we have found that depending on the location of the clinic and their experience, the ICCAP and allied health staff can be really helpful in helping organise the clinics. But by comparison, the clinics we set up through H&E, I think required more work from us. Places like Muswellbrook took a couple of years to get going, and I think primarily the engagement with community was a bit more of a challenge. And this is where really we turn to people like Alwyn and Mandy Howard, who you'll see in our video, to get the community engaged and on board, and occasionally to convince people that it's okay to come up to a facility which they may not have fond memories of. The ICCAP staff has been tremendous not only in the engagement, but they provide point-of-care testing for many things like hemoglobin A1C and ACR. They do transport people around. But I think most importantly, they provide that critical engagement and follow-up. And I think having people who are in the community has been very pivotal to those clinics working. I would like your comment, Alwyn, on that and how you see your role in those clinics.
Yeah, I can't speak for the other ICCAP workers, but I see my role as, with the point of care testing and doing stuff like that, with the CNC, but mainly I see my role as talking about other stuff. Like I know with Matt Crawford, our CNC who's based at Tamworth, he will tell you that a lot of them, you could talk to about their BSLs for ages, but it's the other stuff like that they don't talk about, whether it's 11 people in the house or whether it's their brother going to jail, and or could be anything. Like that's an extreme scenario, but it's quite normal too for us. And I see my role as just talking to them about some of their social and emotional issues that's happening, or their mental health stuff, and organising appointments with them for other counsellors. I am a mental health worker by trade, and I've worked, Mungandai, Weewar, Boggabilla. I've been out this way for 20 years. I've been in ICCAP for a bit more than 5. So I know some of the people, and the last thing I talk to them about is their BSL, because they've seen more specialists than I have, or it's just a normal part of their life. And I find getting a lot of their social emotional stuff sorted helps the rest of their stuff, because I know in our community, the last thing I'm worried about is eating 4 slices of bread for dinner with a curry, and a cup of tea with 2 sugars, because I've got other issues on my mind. So, and that's the sort of stuff I like to talk to them about. Yeah, does that make sense?
Absolutely, mate.
Yeah.
Because that is the stuff which the physicians like me often overlook, and understanding that stuff is pivotal to tailoring somebody's treatment. You don't put them on 5 injections a day if they can only afford 1 meal a day, or as you said, there's a whole lot of competing interests for them. So I try to take that stuff into account, but again, having you give me the heads up on the fact that there are these issues, and then helping the person work with those is easily as important, probably more important than what I write on the prescription pad or tell them to do with their diet. So absolutely essential information for me, and critical engagement for the patient. I'll go to the next slide then, mate. Thank you very much. So the weekly telehealth is the other modality we use, and I was sceptical about the utility of seeing somebody only via telehealth and never meeting them in person, but I'm not going to drive up to Mungandai anytime soon. And Mungandai is only the most extreme, but by no means the only distant place we deliver to. So we do it every Monday from 1 till 4 p.m, and I have a few slots available each week. Alwyn can make referrals, the ICCAP team can book people in, and of course if GPs refer to me, we can give that option too. And again, while I sit comfortably at the John Hunter here with a video camera, the patients will have somebody with them to attend either an H&E facility or their medical service, or even at their home, and have someone like Alwyn or one of the other staff with them in attendance as support, which I think they appreciate. And I think to confirm that the message has gotten through both ways, that I haven't overlooked something important to the patient, and that what I've said has not been over their head or overlooked. And I usually back that up with an email to the person who's with them, the staff member. They can print that out or give it to the patient so that there's clarity of feedback. We always have a discussion at the end of the telehealth clinic just to feedback on other patients and other processes that we're working on. But again, I don't think that would work without people like Alwyn being out there to engage people and to hook them up on the computer and to be with them to support that. More to add, Alwyn? Do you agree with that?
Yeah, and it's. I think like one of the best stuff about my role is that when you do say, can I have, Joe Bloggs there at 2:00, then I know exactly where Joe Bloggs is at 2. And organise it. But it's a prep too. It's seeing him every day prior to them coming in and saying, you're still right for Monday, you're still right. And having them here on time. So, I think the telehealth, and it's proven with that last client that you've emailed me about, Pat, things are just going great guns. And it's worked out well in so many areas in their life, not just their their diabetes.
Yeah, I reckon so. I think we're managing to get to people who I think otherwise would not get that specialist input, and not doing it too badly. I agree. I think I've been surprised at how well things have gone. All right, so I'll skip on to the next slide, which is, I guess, talking about the points which I think have been critical to things working well. I think we've touched upon most of this. I think the role of the clinical nurse consultants and our Aboriginal health workers has just been pivotal to making any of this work. We need you guys for the engagement with people and, like you said, knowing where folks are and getting them to actually connect with us. And obviously your feedback to us about what people need particularly, and obviously your ongoing attention to following them up and making sure they get that has been terrific. I think with the general practitioners, communication with them is very key, and I do wonder that sometimes we could maybe do better, but that's on me to improve my communication. Again, the ongoing relationship with all the AMSs has been critical, and we've been fortunate in that we've had good continuity of contact with them. From the position of, what I think is critical about what I do, I think the continuity has been key. I don't think I've missed any clinics to Inverell except during 2 different sandstorms, and then when we couldn't fly due to COVID. So about 3 clinics we've missed in 11 years. And I think that is so key, and I try and encourage my trainees to maintain that continuity for the 2 years we got them. The benefit for me is I've got a foot in both camps, so I can connect with people out west, but then I can come back to a big hospital here and talk to experts in the field about things I may be struggling with, like difficult to control epilepsy, or I can get investigations, and I can get a hold of the data. So if somebody has been in our facility and had a lot of tests done, which were not conveyed to the local doctor, I can look it up in no time. So I've got access to resources which are difficult for people outside the tertiary hospital, and equally people in here can utilise my services too. So if somebody's going back to Moree with a new heart valve in, I can keep an eye on them with Alwyn's help and make sure that things are continuing to plan. The other critical point for me is I think it's very important to expose our young doctors to working outside the big hospitals. I think you can do your entire physician training without leaving a tertiary hospital. And should you then, by fate, end up out at Mungadai and Moree trying to provide medical services, you would have no idea how to go about it or what the issues might be, whereas I think we've got a generation of young doctors who do have a clue about these things. Alwyn, again, I invite your comment, except I should say thank you to the flying doctors for transporting me up to those difficult-to-get-to places. But, Alwyn, any other things you think we do that are particularly important to make things work as they do?
I think it's that it's a bit like your paycheck. You know it's there all the time, provided you do the right thing. And for me, like, we warn knows that I go down there once a fortnight, regardless of whether I'm with Matt or not. And it's just a quick yarn. I don't want to sound terrible by sounding like I don't care about the people in Toomla and their BSLs or anything, but it's more about the social and emotional stuff that I try and talk to them about, so that they could have other things to talk about.
Mate, we can't do one without the other. We can't get the medical stuff working without dealing with the social and emotional side.
Yeah, and you know, like I remember we had those sensors when we were trying the sensors, and I'd go and have a look at their numbers, and I'd grab the reader off them, and they'd look at me and they'd go, "Oh, you know, my numbers are 25," and I'd go, "Okay, look, let's just talk about what you're eating. I'm glad you ate that. I'm glad you had 2 blocks of chocolate. Let's see how it goes with 1." And it's all those little things, but seeing them all the time, I think, is that key thing that keeps them a bit more focused. And I'll go back again, Pat, to that last email about the client you sent me for the new sensors. You know, it's good seeing her and talking to her about some of the issues that she has settled. that, and other stuff around what's happening at home and everything else. So while her BSLs and her diabetes is coming underway, I get to yarn to them about other stuff and stuff that I know, like what's recently happened in the community and how it's affected one family. So, it's pretty good.
Thank you, mate. I think I've got 2 slides to get through, so I'll kick to the next one, which is, I guess, I've called it progress, so I wanted to talk about what I guess we've achieved. And I find it hard to enumerate this. From my point of view, my position as a senior staff specialist doing this, I think has become accepted by the executive area wide as something worth doing. Personally, I don't think 1.5 position is enough for what we're trying to cover, but it's a new job, and I think the concept has gone around well, so I'm happy with that. We don't do high volumes. I think between me and my trainees, we see about 900 or so people per annum, but I think we do talk to the ICCAP team and GPs about a large number of other people and provide that consultation service. So it is, I think it's low volume, but the people we're dealing with are people who are complicated both medically and socially, and I think who we can help and wouldn't otherwise be able to. In terms of training, I'm really pleased with how that's going, because I think in the 10 years there's over 40 people who are now physicians who have developed some understanding of working outside the major centres and a bit of competence, perhaps, in working in both rural and Aboriginal health. About 20 of those people are now consultants working within H&E, and even more gratifyingly, they're doing the work that I no longer have to do quite so much of. So we have created a generation of, I think, more competent senior physicians to work in the country. I think we have managed to establish good relationships with both the Aboriginal medical services and a bunch of GPs up country who value our input as needed. And finally, quite gratifyingly, we've got a number of mates coming on board from other specialties, so nephrology, cardiology, respiratory and diabetes and so on are coming on board more and more. And also I've got past trainees who are now taking positions up in the regional centres and providing a really good service. So I think the training has been important to me in terms of providing a long-term solution to trying to help people get access to high-level healthcare when they're geographically separate from the big centres. So I'm on to my last slide, which is to finish, and I do appreciate the opportunity to talk. Alwyn, before we'll put on the video directly, which is a demonstration of what we do at our clinics, but have you got anything more to add to sum up from your point of view?
No, just that I think one of the best things that have happened for the Aboriginal community is the use of telehealth, for us to be able to sit down in Mungandai and have you 600 kilometres away saying, I think you need to change your injection spots, or, I absolutely love the telehealth, and just that ability to communicate real easily. So,
well, mate, thank you very much. With that in mind, I'll thank our prospective audience for their attention and hopefully be there on the day to answer questions. Thanks very much.
No, thank you.
Did you know about 80% of all Aboriginal and Torres Strait Islander deaths between the ages of 35 and 74 are due to chronic diseases? Chronic diseases are long-lasting illness conditions with persistent effects, and for the Aboriginal and Torres Strait Islander community, these illnesses include heart disease, diabetes, liver disease, lung disease, and strokes. The Hunter New England Local Health District has identified the need to provide services to address chronic disease, and in partnership with multiple Aboriginal communities have implemented the Integrated Chronic Care for Aboriginal People program, or ICCAP for short. 8 factors have been found that are thought to contribute to the success of chronic disease programs for Aboriginal people. These factors are Aboriginal community support and involvement, partnerships, participation and professional development of Aboriginal health workers, adequate resources, early detection and intervention programs, local multidisciplinary teams and access to specialists, local agreed evidence-based clinical protocols, and follow-up care. You'll hear firsthand from some of the workers and community members who use the service from a variety of areas within the local health district.
I'm Donna CLUCAS. I'm the clinical nurse consultant with the Aboriginal chronic disease team. I'm here at Muswellbrook today with some other clinicians, a dietitian and a diabetes educator, and Pat Oakley, our staff specialist. So we come here to Muswellbrook on a monthly basis, and every second month we bring Pat with us to come and see some of the community here and talk to people about their chronic disease. The clinic's all about forming relationships with the community up here and building some trust and rapport so that people can feel comfortable about coming to talk about their situation and their illnesses and how we can help them better in terms of managing things like diabetes or heart disease. The clinic's pretty unique in that we come to people. Instead of asking people to come down and see us at John Hunter or come down to Newcastle and spend 2 hours on the road, we actually bring the health care to people. And because of that, we run a fairly flexible clinic. It's friendly, it's welcoming, and it's been accepted by the Aboriginal community here in Muswellbrook. The clinic itself is actually driven by Mandy Howard, our Aboriginal liaison officer here in Muswellbrook, and she's a local Aboriginal woman, and that's important that we have Mandy here because that builds that trust and rapport again with community. And a lot of the community know Mandy and vice versa.
So my name's Amanda Howard. I'm the Aboriginal Health Liaison Officer based at Muswellbrook. I cover the 5 hospitals. We're just on our way to Aberdeen to pick up a patient for the clinic. We get a lot of referrals from me just being in the community, going to the supermarket, going out on family outings with my family. People come up to me and just generally ask if they can come to our clinics.
We're getting, regular people turning up each month to come and see us. People are wanting to engage with their health and talk to us about their health, and I think that's in itself been a great achievement for our team.
I had these sores on my legs, and no one knew what they were till it got infected on the ship. Yeah. And he said, "You've got diabetes, that's diabetic ulcers on your legs." And they had to bring them down, they're all swelled up. So I've had them about 8 years now. Pat was the one who sent me to Newcastle. I was down there for 3 weeks. They debrided all the legs, took all the rubbish off it, whatever you want to say. Yeah. And one's sort of healed up, but the other one's still it's got a sore that we can't get rid of. I don't know how many times I've thanked Pat, and anyone else at DONNA and ones that come up here. It's I suppose it's doing us free. They don't have to leave where they are if they don't want to. Yeah. And there's people go all over the state, like DONNA and Pat. And there's a heap of them do things that others wouldn't do, and it benefits the community. And I reckon it's a darn good thing.
I was diagnosed type 2 diabetic back in 2004. I was placed on insulin 3 times a day. I was on 120 units, and then February 2016 I suffered a massive stroke. I was in hospital for 3 months. I was released under the TACCIP team, which they help you for 6 weeks. After the 6 weeks I didn't have any help because the Hunter Valley only really cared for the aged care, and I was out of that category because I was only 48. I was diagnosed with a rare genetic brain disorder called moya moya, which is the narrowing of the arteries to the brain from the base, and you can have a brain aneurysm. There's no warning for that. So just managing my sugars December last year. I had sugars prior to the stroke of 20s and 30s, and now I've got my sugars way down under 10. If it wasn't for the diabetic clinic up here, Mandy Howard, the Indigenous, like with DONNA and Susan, they've been great. Like Mandy, because I can't drive because of the stroke, because I've got left side neglect, I can never drive ever again because of the moya moya. Mandy Howard, she comes to pick me up and takes me to some appointments. So there's DONNA, there's Mandy, but Dr Oakley, the endocrinologist, I got introduced to him a couple of years ago, and he's been just awesome. He has been amazing. I couldn't have asked for a better doctor.
I got lung cancer I can come up here to see Dr Oakley for my pain. It's a godsend. It's someone that they've been there to tell me that they understand what I'm going through. It's been a miracle to me. They're good to talk to.
You're supposed to be happy,
No, I'm supposed to be. No. Yeah, no, they've been really good. They've helped me a lot. And I wouldn't... Even Donna rings up and she's not busy and just to check on me, see how am I going, or she calls around home and see how I'm going. But they go out of their way to do things, which I really, really appreciate.
So we can provide follow-up to the community. That's part of my role as the clinical nurse consultant for the team, is that I can provide that phone call follow-up, a week later and ask people how they're going, and if we did put some interventions into place from this clinic, how are they going with that? How are they going with the new medication we might have started somebody on? Have they got their appointments to see other specialists? As I said, that's part of my role, and Mandy also follows them up in terms of her position here at the hospital. Yeah, people can stay on our books for a long time. There's no end date to our service. We can keep people on our books for as long as they need to be. It's really patient driven and how they want to engage with us. So if we do get people moving out of area, we've got the capacity within the rest of the integrated chronic care team to refer patients further. If they travel, if they go and see family members, we can refer on to our own colleagues. We also have contacts otherwise in other areas, so if people go to Dubbo or any of the other localities around New South Wales or interstate, we certainly have contacts around that we can refer people, and that's part of our role as well. The other benefit, I guess, is that we do hold the clinic at the hospital, so we can actually access pathology quickly. We can actually, access the X-ray department. If somebody's really sick, we can get them into emergency, so that's been of benefit. We do bring point-of-care testing equipment, so again, patients can get their results really quickly, and we can talk to people about their results, and they can get answers to their questions really quickly.
I must admit, the Indigenous clinic up here have been amazing. Like, they really are. There's truly, they just the caring, and it's not just because I'm Indigenous, it's because their nature, they go over and above what you really need.